the air pollution problems and cardiovascular diseases. Dr. Kavita, please. She need not to be required a special mention because we know her as an interventional cardiologist. Now we will see her the preventive medicine efficiency of presentation. Yeah, thank you.
Thank you. Thank you all so much. Ma'am, I need to share my screen.
Not yet.
The host disabled participant screen sharing.
No, no one is sharing actually. You have to start sharing.
Ma'am, someone is disabled the participant's screen sharing actually. So maybe our technical person, that fellow has to. Will it allow me to share? Yes, ma'am. Now I can share.
Yeah, please.
So good evening, everyone, and thank you so much, ma'am, for inviting me for the session. So today we'll be discussing about air pollution and cardiovascular disease. So cardiovascular disease accounts for 60 to 80% of air pollution related deaths. And the European Society of Cardiology also launched a campaign in 2015 to raise awareness of detrimental effects that the environment can have on the heart. So air pollution is composed of the particulate matter and the gaseous components. Particulate matter is classified as into three types: the coarse particles, the fine ones, and the ultrafine particles. So we'll see their size. So coarse one is which is 2.5 to 10 micrometer, which if these many numbers are combined, it makes one football. Similarly, ultrafine is the one less than 0.1, and large grain of sugar makes these many number of particles into one. So fine particles and ultrafine particles. So we can see that in the same mass, we have higher surface area because of the structure. So potential factors contributing to toxicity of ultrafine particles, because there's a large reactive surface area and they have great capacity to carry harmful surface chemicals, complex composition of many combustion-derived ultrafine particles, high deposition in the alveoli of lung, uptake and activation by inflammatory cells, smallest nanoparticles that also can pass into the circulation, and they accumulate in peripheral organs where they can start inflammation. So these are the various fine and coarse particles emitting sources directly or formed in air from various gases. Now particulate matter definitely size matters, as I just now said. So particles more than 10 micrometer are trapped in the nose and throat and never reach the lungs. However, between 5 to 10, they are removed by physical process in the throat, and smaller than 5 micron, they reach bronchial tubes. Particles 2.5 micrometer in diameter or smaller are breathed into the deepest portion of the lung. Identified blood-borne mediators are released, neuroendocrine system is activated, and particles get translocated into the circulatory system. And all these things, they come into finally our cardiovascular system, cardiovascular compartment, wherein in the heart, they are capable of causing arrhythmias, reduced heart rate variabilities, delayed cardiac conductance, increased sensitivity to ischemia, and propensity for heart failure. While in vessels itself, they cause increased sensitivity to vasoconstriction, impaired endothelial function, increased arterial stiffness, increased blood pressure, and exacerbation of atherosclerosis. In blood, they cause susceptibility of coagulability, they cause platelet activity to be increased or to be impaired, and they cause leukocyte activation increase, they cause reduced fibrinolysis, and dysfunction of high density lipoprotein. So all these things, they lead to increased cardiovascular morbidity and mortality. Now these inhaled particles, when they work through neuroendocrine system, the particle translocation mechanism, they cause systemic inflammation, and blood-borne mediators, they work on cardiovascular system. Through same mechanism, they can work on brain, kidneys, metabolism, placental fetal circulation, and cancer also they can cause. And increased thrombogenicity increased blood pressure, increased endothelial dysfunction, leading to lots of preeclampsia, placental vessel remodeling, etc. They are responsible for dysfunctions in brain, kidney, metabolism, and cancers. Now, the biological pathways where particulate matter of 2.5 size promotes cardiovascular events. So, as we just saw, the neural mediators also involved, the oxidative stress, direct translocation, and biological intermediates. So, in direct translocation, they cause autonomic imbalances, endothelial dysfunction, hypothalamus pituitary axis activation, systemic inflammation, and thrombotic pathways they activate. So, lots of increase in adhesion molecules, decreased vasodilatation, increased vasoconstriction, increased proliferation, increased inflammation, and leading to smooth muscle proliferation, the basic hallmark of our atherosclerosis. Also, increased inflammatory cytokines, leading to almost a low-grade inflammation, which can obviously exist all through when we are exposed to these kind of pollutions. Now, there's sufficient epidemiologic evidence to conclude that there is a causal relationship existing between short-term and long-term exposure to this particulate matter and mortality. This is a scientific statement. Short-term exposure to elevated levels of particle pollution can worsen heart fatigue, heart failure, heart attacks, strokes, and some arrhythmias. And long-term exposure to air pollution can have more long-term effects such as development of atherosclerosis acceleration and contributing to premature death. Now, short-term increase in air pollution has been shown to be capable of triggering acute coronary syndromes, and the strongest association has been seen between the concurrent day and 2 days of mean air pollutant exposure. Regarding the risk of specifically STEMI, a recent study is there which has shown that 10 microgram per meter cube increase in PM 2.5 during the 24 hours pre-event was associated with an increased risk of 2.8, while if there is an increased exposure to NO2, there is an increased risk of almost 5.1 for ST elevation MD. The risk related to PM appear to be greater among the elderly, while younger patients they seem to be more susceptible to NO2 exposure. Short-term increase in ozone was also associated with acute coronary events in middle-aged adults with no pre-existing cardiovascular disease. Association between air pollution and malignant arrhythmias has also been reported by studies on patients who had implantable defibrillators. Short-term variations in MP2 and ozone have been associated with out-of-hospital cardiac arrest also, as many other studies also to show this. There was a positive association between short-term increase in PM and gaseous components like NO2, SO2, carbon monoxide, and increased risk of hospitalization or death from CHF, with the strongest association on the day of exposure and more persistent effect for PM 2.5 exposure. Now, many studies have demonstrated that the risk of hypertension increased by exposure to air pollution, most especially the traffic-related pollutants. Now, if you see this figure, the contribution of air pollution versus other risk factors to global mortality. So we see that the total pollution, this is a global estimated deaths in millions, and here is our total pollution, which is contributing to maximum of it. After that comes the air pollution, second to it, then tobacco smoking, then comes these infectious diseases, then alcohol, then malnutrition, accidents, drug abuse, and other things. Now, this is a diagram showing the particulate size seen in different parts of globe in amount of their distribution. So much so that the Lancet Commission developed the framework of the pollutome, a subset of the exposome, defined as the totality of all influences of pollution on human health, including exposures across the lifespan. So the health effect of pollution and air pollution in particular are likely only the tip of iceberg. We will be seeing in this figure that the zones of evidence linking air pollution and cardiovascular disease. So the zones for which we have well-characterized adverse cardiovascular effects evidences, all-cause mortality and cardiovascular mortality. However, if there are emerging evidences for hypertension, diabetes, non-fatal MI, non-fatal strokes, and heart failure. Inadequate evidence of association, which need further research for thromboembolic disease, atrial and ventricular arrhythmias. There are four main types of air pollution sources, including natural areas, stationary, mobile sources producing these particulate matters of different sizes, reactive gases, including volatile organic compounds. Human sources, as we all know, industrialized or urban areas. Stationary sources are power plants, and the mobile sources are motor vehicles. Air pollution concentrations are high enough to harm human health or alter it. Natural sources are also there, which cause pollution, like dust blown by wind, pollutants from wildfires and volcanoes, and volatile organics released by plants. Now, these are the different sources and types of air pollutants we have. Like the natural source, the primary pollutants could be these many number of gases, and the byproduct of them, which is the secondary pollutant, can be these many number of gases. Of course, the human source can also contribute like this, and these primary pollutants can make the secondary pollutants, but they do so. So this is again the extension of the previous figure. So natural, we have the volcanoes, the lightning, the wildfires. These are the areas of cities, the livestock, fertilizers. Stationary things are like industries, power plants, sewage treatments. Mobiles, we have these all airplanes and vehicles which are moving around. And secondary pollutants there, as I showed in the previous slide. These are the primary pollutants. By photo or chemical activation, they make secondary pollutants. So these all are so many chemicals which are released by all these sources which we have around us. Now, this is a study showing air pollution and relation of sudden cardiac death. So they studied 8,434 sudden cardiac deaths in suburban Melbourne over a 4-year period. Mean age was 72 years, and males were more. The mass daily average PM 2.5, PM 10, ozone, carbon monoxide, NO2, SO2 levels just prior to arrest with levels over the previous weeks. And 24-hour air quality measurements from a single EP recording site was done. Increased risk of out of hospital cardiac arrest, increase in PM 2.5. So they found that 4.26 microgram per meter cube increase in PM of 2.5 size leads to 3.6% increase in risk of cardiac arrest. Now, similar findings when the Melbourne study was repeated in Perth, increased carbon monoxide and increased PM 2.5 led to increased out of hospital cardiac arrest. Repeated in Melbourne at time when PM increased 2.5 from 2007 to 2008 bushfires, and 24 excess OCHA during the 12 days of fire. Now, how might exposure to PM 2.5 predispose to acute coronary events and cardiovascular disease? So the data from Framingham Heart Study shows that acute exposure to relatively low air pollution during 2.5 is associated with increased markers of systemic inflammation, as we have seen in the previous slides. And there are several meta-analyses, including from ESCAPE project, showed that association between air pollution and atherosclerosis. Multiple studies showing changes in autonomic regulation of the heart following short-term exposure to traffic pollution in cyclists. And this occurs in young and elderly people. Occurs if more pollution, busy road versus quiet road, but obviously. So there's a question that could improving air quality have an effect on health? Yes, they found that as exposure to PM 2.5 decreases, we can have better quality of health around us. Now, this is typical picture of our villages. So this is the exposure response relationship of short and long-term effects of PM 2.5 and ozone with mortality. So we can see clearly that as PM 2.5 exposure increases, there's a relative risk increase in mortality from here to here. Similarly with the ozone and mortality. Chronic PM exposure and cardiovascular mortality, clearly we are seeing high ozone zone and low ozone. So there's no doubt that it increases mortality. Now, if we compare this 1990 rank in 2015, and if we see the behavioral risk, environmental or occupational risk, and metabolic risk. So in 1990, high systolic blood pressure, now it is high systolic, smoking and smoking. Childhood undernutrition was 1990, now it is high fasting plasma glucose. Here it is now total cholesterol. There it was ambient particulate matter pollution, household air pollution, and here at fifth place again it is ambient particulate matter pollution. Now, so summary of pathophysiological mechanisms by which air pollutants cause increased oxidative stress, inflammation, thereby contributing to cerebrovascular, neurological, mental, and cardiorespiratory disorders. So we have seen this all. Reactive gases are these common ones: carbon monoxide, SO2, NO2, ozone, and these are volatile substances, PM of different sizes. So again, they lead to autonomic imbalances, HP activation. I think same which I see for fibrotic and atherosclerotic pathways, systemic inflammation, platelet activation. They are the common things. So in US, air pollution deaths comparable to Alzheimer's and diabetes and flu. So they found cardiovascular disease 740, cancer 585, chronic respiratory, and there are number of deaths in thousands. So these were the number excess deaths attributed to outdoor air pollution in the US. Now, short-term exposure to air pollution, if we see it in this pyramidal shape, severity of acute health effects. So here we start from here, where we have unnoticed physiological changes in our lungs. Then comes the symptoms of irritation to eyes, nose, and throat, which all of us, or those who stay in cities, we feel it very often. Then we start using some medications. Then we have obviously some restrictions of our activities, day-to-day activities, reduced performance. Then we visit to a doctor, and emergency department visit might be happening because of the increased blood pressure or atherosclerosis, STEMI, or non-ST elevation MI or heart failure. Then admissions and premature mortality. So this all starts from this beginning of unnoticed physiological changes in lung functions, starting with the pollution. So we need cleaner air for all. And we all know that heart matters. Now, this is pulmonary oxidative stress and inflammation, subacute and chronically. It keeps on giving us systemic spillover. Acutely, activation of lung and ANS reflex arcs, ANS imbalances. So vasculature responds to it by vasoconstriction, endothelial dysfunction, and blood has increased platelet aggregation. Acute or chronic, PM and constituents transmit to blood, that is translocation, and these vasculature again responds to it by increased BP, atherosclerosis, and all those things. So they are all common things happening in this pollution exposure. So this is the scene we see. This is a picture from China. Now, we all know that this atmosphere is divided into so many layers. So what are the major outdoor pollution problems? The pollutant mix in the air to form industrial smoke primarily as a result of burning coal or photochemical smoke caused by emissions, motor vehicles, industry facilities, and power plants. Burning fossil fuel causes air pollution. And this is indoor pollution, one more picture. Chemical reactions that form major outdoor air pollutants, carbon monoxide chemical reaction. So this all we know. Science focus detecting air pollutants. So we can have various chemical instruments, satellites, lasers, and remote sensors, which can sense the air pollutants around us, and biological indicators. Natural capital, the lichen species, they can be used as an indicator of air pollutant. Now, indoor air pollution is a serious problem. In developed countries, indoor air pollution is greater than outdoor air pollution. Why? Because 11 of the common air pollutants higher inside than outside, greater in vehicles than outside, and health risk magnified. People spend 70 to 98% of the time is indoor in cars. Indoor air pollution is a serious problem. Who is at greatest risk from indoor air pollution? Children under 5, and elderly, sick, pregnant women, people with respiratory disorders or heart problems, smokers, and factory workers. The most dangerous indoor air pollutants: tobacco smoke, formaldehyde, radioactive radon, and very small particles. So this is some important indoor air pollutants. We all know them, we see them. Now, what are the solutions? Solutions are at big levels, basically. So reduction or disposal, prevention. For motor vehicle air pollution, we can clean up, which requires emission control devices, inspect car exhaust systems twice a year, and set strict emission standards. For indoor air pollutions, use adjustable fresh air vents for workspaces, circulate air more frequently, circulate a building's air through rooftop greenhouses, use efficient venting system for wood burning stoves. So we know this stove in our areas. So this is the country situation. So State of Global Air 2017 report, which says that globally air pollution caused more than 4.2 million premature deaths in 2015. As many as 92% of the world's population lives in area with unhealthy air. India and China together were responsible for over half of the total global premature deaths due to air pollution. So to conclude my talk, exposure to air pollution increases long and short-term cardiovascular mortality, though an increase in myocardial infarction, stroke, and heart failure events. There is no safe threshold, however, below which there is no effect of pollution on the health. Public awareness of the health risk of air pollution has never been a good one, and it is rarely a subject of media discussions. While we may have known for many centuries that air pollution is damaging to our health, it is only last 2 decades that the full magnitude of the problem has been recognized. So the available scientific evidence supports the plan that efforts to reduce exposure to pollution should urgently be intensified and supported by appropriate and effective legislation. Citizens are entitled to clean air, just like clean water and safe food. Breathing is a prerequisite of life. We breathe from the moment we are born until the moment we die. An adult breathes 15-meter cube of air every day. More air enters the body and blood than any other substance. Thank you so much.
Thank you, Kavita, for the very precise and complete coverage of all the aspects of the air pollution. Can I ask one or the two questions, if you permit? Yeah. The major thing is during the lockdown period, almost air pollution has come down. While we are going to the airport or coming, we used to see the display of the degree of the air pollution in the city. So, is there any studies that during these lockdown periods, not only from India, then other areas, acute cardiac events are decreased as the precipitating factors are decreased? If anyone has also an idea, they can answer. I have not come across for any studies. I think it is worth seeing. Sudha Bala is from the ESA hospital. She has done a study on which is published in the Indian Journal of Cardiovascular Diseases for the industrial air pollution and the incidence of it. I think this may be an ideal time to see that effect of the air pollution decrease of the acute events. Probably long-term events of the only the shorter duration of 1 month or 2 months may not have the long-term then effects, but definitely then acute events might have been come down. Anyone want to add anything?
Actually, during lockdown, madam, we also saw a significant decrease in the number of acute cardiac events. But then there were a lot of confounding factors in that. In addition to the reduction in air pollution, there was also a reduction of stress because a lot of people were staying home and not exposed to their stressful work environment. In addition to that, people were getting adequate amount of rest. So there were a lot of confounding factors during that period. But yes, hospitals saw a dramatic decrease in the number of coronary artery disease cases which came to the hospital. So there was definitely something there. But I think a lot of factors contributed to that.
Yeah, probably comparison of the first wave and the second wave may be helpful, because then the first wave, the anxiety, the stress was different, and second wave stress was different. And the second one is the air pollution decreases the same in the first and in the second waves. So I think added now the second wave is more problematic, mainly because of the increase in the mortalities and the more stressful situation of the COVID that is also contributing. So probably comparison of the first and second wave may be able to take out some of the effects of the stress, and we can know it. But major problem of the decrease of the acute coronary syndromes at the end of the first wave, many of the studies has come saying that it is not possible for the person to reach So many of the acute coronary syndromes are staying back in the house. So just by hospital admissions, we may not able to, but it is maybe the worth seeing it. Yeah. If there are no further comments, I invite now Sarita to take over the clinical meeting for the Madhya Pradesh. Dr. Savita, please. And I'm very, very thankful to her as she is an active member and she does every work within a few minutes and seconds, I should say it. In the last minute, she could arrange so excellent clinical meeting. I'm really thankful to her. Dr. Sarita, please.
Thank you, madam. I'll just share my screen and start off.
Before Sarita starts, Vijayalakshmi madam commented that post-COVID thrombosis has increased in MI. So we are talking about air pollution. Madam brought a good important point that yes, thrombosis because of the COVID was increasing in MI.
Is my screen visible?
Yeah, it is visible.
So today I'm going to be talking about management of pulmonary embolism, a case-based approach. So we do know that DVT and pulmonary embolism, they're leading cause of death worldwide, and it has been estimated that at least 3 million deaths a year occur because of it. And why is it so important, this syndrome complex of venous thromboembolism? It's because it can produce a fatal pulmonary embolism leading to death. There's a high risk of recurrence, also post-thrombotic syndrome. We also have chronic thromboembolic pulmonary hypertension, which lasts as a sequelae to this. And there is a high bleeding risk of long-term anticoagulant treatment, and of course, the economic burden, which is borne by the patient. Now, if you look at the pathogenesis, when we talk about venous thromboembolism, it's usually triggered by the virtuous triad of venostasis, hypercoagulability, and vessel wall inflammation. Now, all of these are clinical risk factors for DVT and pulmonary embolism, which we talk about. They all have their basis in one or more of the elements of this triad. So there are a host of risk factors which we frequently talk about, and most of them are prolonged immobility, a post-operative stay, severe blood loss, heart failure, varicose veins, advancing age, obesity, postpartum situation, malignancies. So a host of these are risk factors for developing DVT and pulmonary embolism. Now, how do we go about doing an initial evaluation and diagnosis? The most important has always been the history taking, the signs and symptoms. So a classical presentation is an abrupt onset of a pleuritic chest pain, shortness of breath, and hypoxia. But a lot of patients, they don't have any obvious symptoms at presentation. These symptoms may frequently vary from a gradually progressive dyspnea to a sudden catastrophic hemodynamic collapse. So there's a wide spectrum of ways in which these patients present. A lot of these patients also come in with atypical symptoms such as seizures. They might have a syncope. They might complain, of abdominal pain or fever, a productive cough. Sometimes they come in wheezing. They sometimes have a decreased level of consciousness, new onset atrial fibrillation. That also we see many times. Sometimes some hemoptysis or a flank pain or delirium. Now, all of these are atypical presentations, but it should come to our mind that are we dealing with a pulmonary embolism? A lot of clinical scoring systems have been developed to determine the clinical probability of pulmonary embolism. Before proceeding with the testing, the two most commonly used ones are the Wells score and the revised Geneva score. So based on this, if the score is greater than 6, we think that there is a high probability of pulmonary embolism. And if the score is less than 2, we say that there's a low probability, and in between, we have an intermediate risk. So when you have a patient who's suspected and without hemodynamic instability, then you would probably look at the clinical probability. if there's lower and intermediate probability, you would look at the D dimer and then decide based on that. But if there's a high probability, most of these patients go in straight for a CT pulmonary angio and confirm the diagnosis when we start the treatment. However, in a patient with hemodynamic instability, the most important tool is a bedside echocardiogram. And if you find the evidence of RV dysfunction, then you would probably go in straight for a CT pulmonary angio if possible. If not possible, you would treat anyways. So in the diagnosis, importantly, we talked about the history, the examination, but we'd also look at certain investigations such as the ECG, the serum studies such as the D dimer, the troponins, the natriuretic peptides, the X-ray, the echocardiography, and of course, followed up with further investigations such as VQ scan, which we don't use so much nowadays, the CT pulmonary angio, which we use a lot, and the gold standard, the pulmonary angiography. The X-ray is frequently abnormal, but about a fourth of these patients, they don't have any findings on the X-ray. It's not sensitive or specific test, but you might find things like cardiac enlargement, pleural effusion, elevated hemidiaphragm, sometimes a pulmonary artery enlargement, atelectasis, and parenchymal pulmonary infiltrate. So you could find features like a pleural-based opacification or a disappearance of vascularity of focal oligemia, the Westermarck sign, the Hampton thumbs, all of these may be possible. You look at the ECG, you most frequently find a sinus tachycardia with non-specific STT changes. The RV strain pattern suggestive of a severe pulmonary embolism. You would sometimes find a QR in V1, an incomplete right bundle branch block. The classical S1Q3T3 is only found in about 10% of the patients. Other ECG abnormalities like atrial arrhythmias, inferior Q waves, precordial T wave inversions, ST segment changes are also seen. So this is what sometimes the ECG looks like. You can see the S1Q3T3, the T inversions, late transitions. The D dimer, very frequently we use it. It has a high negative predictive value. It's a fibrin degradation product. And negative result usually excludes a pulmonary embolism safely. But you also have a lot of situations in which it can be false positive, which is why it doesn't have a very high positive predictive value, because it could be false positive in pregnancy, in trauma, in sepsis, in cancer, and inflammation. The echocardiography, very useful for us because it helps us in a rapid triage of the patient, and it should be done in any patient who suspected a massive or an unstable pulmonary embolism. Also, it's very helpful to deciding which patient to thrombolize or give other aggressive therapy. So you could find the right ventricle to be dilated, hypokinetic. You could find an abnormal septal motion. You could also find the thrombus in the right heart in the main pulmonary arteries. You could also find a TR associated with increase in the systolic pressure in the pulmonary artery. So these are images of how it would look, the dilated RARV and the distortion of the septum. Sometimes you can see the clot in the area or in the RV. That's followed by the CT angio, which gives us a direct visualization of the emboli. It's also helpful because you can also look at the parenchymal and the mediastinal structures, and this gives us an ability to detect alternative pulmonary abnormalities, which may explain the patient's clinical symptoms and signs. So it has a sensitivity to the tune of almost 95%. So pulmonary angiography long been touted to be the gold standard for diagnosis, but it's highly invasive. A positive result is a filling defect, and a negative pulmonary angiogram usually excludes clinically relevant pulmonary embolism. Also, if you're going in for a pulmonary angiography, the pulmonary catheter can also be used therapeutically. There are various scores. So we have the scores, and if you look at these, class 1 to class 5, the severity index is looked at, and class 1 patients would be low risk, and the class 5 patients with greater than 125 points considered as to be high risk. So when we talk about management, we look at the pulmonary embolism response team, which is now touted. The patient is suspected pulmonary embolism, you start anticoagulation immediately, confirm it while doing the CT pulmonary angio, and activate the multidisciplinary pulmonary embolism response team, the PERT team. And then you decide based on the available equipment which you have, whether this patient requires a medical therapy, a catheter-directed therapy, or a surgical embolectomy. So this is how we triage the patients. And depending on whether they have hemodynamic instability and require primary reperfusion plus anticoagulant therapy, or they are in the intermediate and low risk group, and anticoagulant therapy alone will do. You also follow them long term to look for any evidence of CTPH or prolonged dyspnea. I have a screen issue. Yes. Now, it's very important when we talk about pulmonary embolism, we also talk about the duration. So if this patient, any venous thromboembolism, if it's a proximal DVT of pulmonary embolism, the duration is usually recommended as 3 months. It's class 1B recommendation. And if it's a first proximal DVT of pulmonary embolism provoked by surgery or any other transient risk factor, it would again be 3 months. And the duration in an unprovoked DVT or a pulmonary embolism could be an extended therapy if the patient's bleeding risk is low or moderate. However, if the patient's bleeding risk is high, again, you would give it for 3 months and reassess. Again, a DVT or pulmonary embolism associated with an active cancer, it's extended therapy recommended beyond the 3-month protocol. So in my first case, I'll show a 40-year-old male. He has a sudden onset of palpitation and giddiness. He had a similar episode 1 year back, but he had no documents. He also has a history of atrial fibrillation in the past, and there is no other significant past history. Now, clinical examination on admission, you could see that his pulse rate was 123 per minute. He had hypertension, his blood pressure was 60 systolic, and he had a few creps and rhonchi in the chest. Now, this was his ECG. This patient was immediately intubated, ventilated, and he was put on a high inotropic support. Now, his blood pressure remained low even after pumping 1.5 liter of fluid. The acidosis was also corrected, but in vain. There was asystole as soon as codron was given, but he was revived after a CPR. I'm sorry, this image is not running well. But okay, so the diagnostic dilemma in this patient was this patient had right bundle branch plug, atrial fibrillation with fast ventricular rate. There was decapitation of the anterior airway. He was in shock. There was no significant past history except a history of a similar episode. His echo revealed biventricular dysfunction. He had a dilated RV with poor RV function with severe low pressure TR. Now, what was the diagnosis? This patient, we had a differential diagnosis. Was this a DCMP with atrial fibrillation and fast ventricular rate causing shock? Was this an acute inferior RVMI? Was this a pulmonary embolism? His TROPI and D-dimer both were positive in the emergency. So a very strong suspicion of pulmonary embolism. We gave him a bolus STK 2.5 lakhs. The infusion was not started as there was a massive oral bleed. But immediately after the STK, his blood pressure improved and his heart rate settled down. A UGI endoscopy was done in the ICU and it revealed multiple bleeding esophageal ulcerations. This patient was extubated the next day and he made steady improvement. Next day, the CT pulmonary angio was done, which revealed a partially recanalized saddle thrombus. A heparin challenge was given to this patient, but he rebled. Henceforth, we had to go ahead and put in an IVC filter, and this patient was discharged the next day. So we put in an IVC filter because we were not being able to anticoagulate him, was not tolerating it. This was the filter that we put in. And post STK, his ECG settled down, went back to sinus. So the final diagnosis of this patient was acute massive pulmonary thromboembolism, cardiogenic shock, recovered, severe LV dysfunction, AF was 30%, severe RV dysfunction, it recovered subsequently. Severe TR, PSP was 45, AF with fast ventricular rate, multiple pharyngoesophageal ulcers with bleed. He had an IVC filter implantation. This is a case we did long back, a 9-5-14, and bilateral chondromalacia patella grade 4. Now, this is another interesting case. A 42-year-old male came to the emergency with sudden onset of shortness of breath. He had a history of intermittent non-exertional shortness of breath for the last 3 years, treated as bronchial asthma. He also had a history of severe pain in right lower limb for the last 8 days. He was diagnosed to have lower limb DVT 2 years ago and was put on anticoagulants for some time and not investigated further. He had no family history of heart disease, stroke, or cancer. He never smoked and he rarely used alcohol. He had a history of bleeding piles. On examination, he had cold, clammy extremities, right lower limb swollen, tender calf, raised local temperature, tachypneic, pulse rate 136, PP 90, systolic, clear chest, no heart murmurs. ECG was suggestive of right bundle branch block, few waves, and sinus tachycardia, echo dilated, right atrium, right ventricle, severe TR, PA pressure was high, 80, normal LV function. The provisional diagnosis in this patient was a recurrent right lower limb DVT, a massive pulmonary embolism, shock, severe TR with severe PAH. CT angio was done, which revealed a subocclusive thrombus in both main branches, multiple segmental and subsegmental branch pulmonary artery thrombus. Hematological investigations revealed severe anemia. Hemoglobin was 6.8, and there were megaloblastic cells on the peripheral smear. platelet count was okay. So he had a near complete, including thrombus seen in left main pulmonary artery extending in the lower divisions. So final diagnosis of recurrent right lower limb DVT, massive pulmonary embolism, cardiogenic shock, severe PH, and anemia. And the query was it nutritional? So he was treated with low molecular weight heparin in view of his low hemoglobin and his history of bleeding hemorrhoids. He improved, but on day 3, he suddenly complained of increasing pain in the right lower limb, which was attributed to ongoing DVT, and he was treated with analgesics and local measures, but he did not improve. And the digits became cold and showed signs of color changes. The Doppler was repeated, which revealed floating thrombus in the popliteal artery, which was treated with an embolectomy. Henceforth, we started a search for the etiological diagnosis, and it was contemplated in the light of associated arterial thrombosis now. So this is a young male, unprovoked recurrent lower limb DVT, admitted with pulmonary embolism and shock, arterial thromboembolism, and megaloblastic anemia. Now the cause, so we usually like to look for a single etiology for both the arteriovenous embolism and the anemia. So in view of both of these, the megaloblastic anemia and the arteriovenous thromboembolism, we looked at the fasting homocysteine levels and the vitamin B12 and folic acid levels were seen. In this case, a detailed workup for hereditary causes of thrombosis. Now, when you look at both arterial and venous thrombosis, this is seen in few situations, and the causes are a hyperhomocystinemia, lupus anticoagulant, dysfibrinogenemia, myeloproliferative disorders in cancers. This patient's B12 level was low. Further limited testing, however, was done with the factor V lead-in protein CS, lupus anticoagulant, done after 3 months after stopping warfarin for 2 weeks. It was done because we found that the homocysteine levels were normal. There was a floating thrombus in a normal artery. However, the histopathology of the clot after embolectomy, we sent it for histopathology. It was suggestive of a venous thrombus. So paradoxical thromboembolism was suspected and not simultaneous arterial and venous thrombosis. This patient's factor V lead-in ratio was low and suggesting a heterozygous disorder. The protein C was also showing low activity. Rest of the parameters were normal. So the etiological diagnosis was hereditary thrombophilia, recurrent DVT, massive pulmonary embolism, recovered paradoxical popliteal arterial thromboembolism. The cause was a combined factor V lead-in and protein C deficiency. Megaloblastic anemia was considered to be nutritional. The patient was vegetarian. Ladies and gentlemen, thank you so much.
Yeah, excellent cases discussed about it. One or two points what I wanted to add is in the diagnostic modalities, always nowadays we are thinking about only the CTPA, but when the patient has a renal problem and significant renal failure, then the catheter-induced thrombosis and especially the jugular veins, they'll keep it as the dialysis hubs for them to do the dialysis. Those people are the much prone to develop. So there we can't do the CTPA. Still in those cases, there is a role of using the lung perfusion scans. So still the role is present, and depending upon that, yes, we require the anticoagulation hiking. In the first case of fevers, I would have been advising when the saddle thrombus is there, mechanical. Either you can do the surgically, which is a very, very high risk in the patient in the cardiogenic shock ward and arrested. And the second one, doing an angiojet and then aspiration is going to be the problematic. Best thing at the time is to push the thrombus in the peripherally. So we think that most frequently it produces the pulmonary infarct and more of the lung damage, but the salvage of the patient is more important. We are fortunate enough that is recovered from the day 3 onwards with a partial improvement. But at that stage, I think the pushing the thrombus to the periphery is one of the good options to do it. About the second patient, this hereditary thrombophilia, you said that it is a thrombectomy done from the arterial system, showed a venous thrombus. You mean to say that it is a predominant red blood cells or the platelets, that is the way they are able to distinguish it? Or otherwise,
yes, madam.
Yeah, for the some time, the thrombus is there. It is not possible to distinguish in the venous from the arterial. So only by the platelet rich or the RBC rich, it may not be possible, but what you said is reasonable. Then you should have been worked out for the PFO, or why there should be a venous to the arterial system also. That may be the contributing. Thank you. Good cases.
So that, madam, that is what we were thinking, that this patient probably had a paradoxical embolism through the PFO. But we were not able to demonstrate a significant PFO on the echo. But it was a normal artery when they did the embolectomy. So we could not understand why there should be a thrombus in a normal artery. So we suspected that this is what must have happened. There must have been a paradoxical embolism, because subsequently there was nothing else which we could find in that patient. Also, his factor V lead-in and protein C levels were low. So this patient was put on long-term anticoagulation, and let's see how he does, madam.
Yeah, that's good. Excellent.
And first case, yes, you were right that, when we could not thrombolize him because of the massive bleed that he had, we could have considered a mechanical. But this patient was very sick at that time. And post that single dose, his vitals came back. He had already arrested. He was already ventilated. So it was extremely high risk. And when he started showing signs of recovery, we were very happy. So we kept him like that.
Good. So can I invite a comments from anyone else? I think Dr. Suma is there. Probably she can add anything extra. Yeah, if there are no comments, please you take over. If this is your area.
Okay. So we would now like to invite Dr. Sanjukta Bhargav to start with her talk. Dr. Sanjukta, please share your screen.
A very good evening to all the very lovely ladies, and I'm honored to be presenting in this platform. Thank you, Dr. Saitara, for giving me this option, this opportunity. So I'm Dr. Sanjukta Bhargav, and I'm predominantly dealing with pediatric cardiac cases. And I have done my fellowship from Satyasai, Raipur, which is predominantly dealing only with congenital heart diseases. So today's case is from Satyasai itself. When I was there, part of the team, we had this case where the child had transposition of great artery with total anomalous pulmonary venous connection beyond its recommended age for correction. So as we all know, transposition of great artery is a very complex congenital heart disease. And transposition of great artery is another very complex congenital heart disease, both separately being very difficult, very difficult to operate, and a very time limited presentation they have. They give us very little time to take a decision and to operate. So transmission of great artery is not uncommon. It almost comprises 3% of all congenital heart diseases. And surgery for transmission of great artery is ideally done within 3 weeks to 6 weeks of age, because the LV, which regresses after 6 or 8 weeks, is unable to handle systemic pressure. So we cannot do arterial switch. So we need a good LV which can handle systemic pressures. So from here on, this child who came to us at 1.5 years of age with anomalous pulmonary venous connection and transposition of great artery with severe PH was actually a win-win situation instead of a very critical situation. So usually when we see a TGA, the minute it is beyond the regular time span, the surgeons or the cardiologists are confused as to what to do. Uh, Even if the LV appears to be normal, still we are more reluctant to take the surgery because of the outcome. Of course, the child will probably not come out of the OT. So always a dilemma, always a glitch when the child crosses 6 weeks of age. Why is that? Again, LV not being prepared for the great systolic pressures. As I said, this child at 1.5 years of age present to us with history of recurrent LRTI with FTT, failure to thrive, with only weight of 5 kgs, length of 65 at 18 months of age. Child was dusky with failure to thrive on examination, was tachypneic, had tachycardia, SpO2 was 85%, all other systems largely normal. Cardiovascular examination revealed S1, S2 present with a soft systolic murmur at fourth intercostal space and apex displaced to fifth intercostal space mid-clavicular line. This is the X-ray which showed cardiomegaly and a plethoric lung field. This is important when it comes to pediatric plethoric with severe when there is severe PAH and a plethoric lung field, it's an indication of operability of the case. On echo, this child showed atrioventricular concordance, arterial discordance. There was a large OS ASD, osteosecundum ASD with right to left shunt. There was severe TR. Septum was intact. Aorta was placed anteriorly to pulmonary artery. RA-RV were dilated, but LV was preserved. So what do I mean by LV was preserved? So because in TGA, LV is pumping to low pressure circulation. Pulmonary artery is low pressure circulation, almost two-thirds of systemic circulation. So LV becomes lazy, it shrinks after 6 to 8 when it realizes it doesn't have to do much of work. So that's why we cannot do the arterial switch surgery. But in this child, even at 1.5 years of age, the LV mass was 58 grams per meter square. Also, there was associated pulmonary veins were forming a common chamber behind LA and draining into SVC via right vertical vein. There was obstruction noted over there with a mean of 10 mmHg. MPAs and branch Ps were grossly dilated, but function was preserved. So our final diagnosis was transposition of great artery with obstructed TAPVC with severe PH and LV preserved. Intraoperatively, our findings were confirmed. The obstruction in the TAPVC or in the vertical vein was due to vascular vice. It was compressed by RPA and right bronchus. So finally, the patient underwent arterial switch surgery at 1.5 years of age with TAPVC repair. Post-operative management, we had to deal with pH, where we followed a regular pH protocol where we sedated and ventilated the child for 48 hours. There was minimal handling and suctioning. Child was put on sildenafil and bosentan for right from day one post-operative period. And luckily, child was extubated after 48 hours, and post-extubation, the recovery was quite smooth. Post-operative echo revealed well-flowing Lecomte. There was trivial neo-PR. There was moderate TR with peak gradient of 30, and there was mild grade 1 RV diastolic dysfunction. So coming to TGA, isolated TGA with intact septum, intact IVS, has, if not operated, has a mortality of 30% in first week, 50% in 1 month, and 90% in the first year of life. What happened to our child? Our child had a preserved LV as a result of increased pulmonary artery pressure and volume overload, which is shunting right to left via the ASD. So single stage anatomical correction is best done when it's between first 3 weeks of life and definitely not beyond 8 weeks of life. But in our case, in this 18-month-old child, the LV mass was preserved, as I mentioned, because there was pressure overload, there was volume overload as well. So the LV did have to work hard to sustain, to maintain, to pump against high pulmonary pressures. Similar case was presented previously in 1994 in European Journal by Gonteja et al. But in that study, he had advised against arterial switch surgery when TGA was associated with pulmonary anomalous pulmonary venous connection. But after that study, we have had few more cases where the surgical outcome in TGA with TAPVC was favorable indeed. But these studies were conducted in really young age. It was again within the recommended time span of 6 weeks of surgery. The most of these babies and these case reports were 20 weeks or 20 days old or 4 weeks old. So uh, our our paper is more important because this child presented to us late at 1.5 years of age. So this brings us to conclude that in congenital heart diseases, individualistic approach is very important. We should not generalize the management in congenital heart disease. Pulmonary artery hypertension in pediatric is not always a threat. We do have large VSDs who have severe PH, but they are still in the operable period. And how do we know that? We know that by putting the whole complete scenario together, by putting clinical findings, radiological findings, and echocardiographic findings together, and concluding whether this patient is operable or not. Clinically, our patient had recurrent LRTI, obviously, which shows the child is not Eisenmengerized yet. The child has increased blood flow. Radiologically, the child, there was no oligemia, the pulmonary plethora was present. So, a complete scenario and individualized approach to congenital heart disease is quite important. So finally, when this child came to us for follow-up after 1 month, child was playful, had gained 1 kilo of weight, had gained 4 centimeters of length, and SpO2 was 98%. Review echo was great. There was mild TR, no PH, there was no neo AR, trivial neo PR, and bilateral function was very good. Child was doing very well. Thank you. I mean, this case is a rare case and not commonly associated, but this brings us to think that should we really have those strict guidelines? I mean, TGAs should not be just sent off because they have crossed the timeline for surgery. Thank you.
Thank you, Dr. Sanjukta. Excellent presentation by you. Dr. Sanjukta is a pediatric cardiologist, and she, along with her husband, who's a pediatric cardiac surgeon, both have trained at Satyasai, and they have joined us at Apollo for the last 1.5 years, and they are doing excellent work over there. So it was a wonderful case presentation, a rare association, very well managed. The house is now open for questions and comments. Dr. Jyotsna, please.
Yeah, actually, it's such a rare combination. It's really great. But only one thing is, it's fortunate that the pulmonary veins are draining to the right side, and that is draining into the LV, and so more saturated blood is going. So probably it is a one way it is good. And here I have a doubt that the increase in the pulmonary blood, like a pulmonary edema feature, may not be a sign of an increased blood flow. It may be because of an obstructive TAPVC. Also, you will have the increased circulation and the pulmonary edema. So, all said and done, the increased flow is a good outcome for these people than the not having that an effect.
Yes.
And Vijayalakshmi madam is also commented on that. It is almost like a natural senning.
Yes.
So, can I ask Dr. Vijayalakshmi madam to comment on this? Abdul, can you unmute Dr. Vijayalakshmi madam's?
Great case and great management. I was extremely happy. I have seen the combination, and the surgeons, they really fear to operate. And good that your husband was there to operate. And whatever we have the set guidelines that it has to be operated within 7 days, 1 week, that is there. But for each case, we have to make the treatment tailor-made. Because of the great combination here, and PH made the LV develop well, So I think that came handy, and you have done excellent, and congratulations to both of you.
Thank you, ma'am.
So if there are no further comments, we will move to our next case presentation. Our next case presentation is by Dr. Abha Pandit. Dr. Abha Pandit is Professor of Medicine at Index Medical College. Dr. Abha, can you please share your screen and start?
Abha ma'am, you would like me to share the screen?
Yes, Dr. Abha, we can see your screen. If you can hear, so it's gone full screen. But we can't hear you. Can you unmute yourself? You're not audible. There's an icon at the base. At the base of the screen, there's an icon. Please unmute. Rahul, can you do it?
No, actually, madam unmuted.
Ma'am is unmuted, ma'am.
Yeah, I think it's the net connection.
Dr. Abha, can you hear us? You're not audible. Rahul, can you unmute it from your, this thing?
Ma'am is unmuted, ma'am.
It is unmuted, but we are not able to hear anything. Can you guide her?
Yes, ma'am, I'll call her.
Dr. Abha, you can try increasing the volume in your speakers on the computer if you're unmuted. Part and parcel of our webinars, no problem.
Okay, thank you so much, ma'am. And it's really, again, a very good evening. And it's really a pleasure to be with you all here today. And thank you very much to you for giving me the opportunity and the organizing team as well. I will be just doing a short case discussion, and which is the patient came with heart failure symptoms, and there was an unusual cause for it. So I thought we should discuss about that. A 56-year-old gentleman, he presented with history of acute onset shortness of breath, and which progressed over 2-3 days. And then he, on the third day, he also had some chest tightness, heaviness, and for that he went to the hospital, and there were no history of any palpitation or syncope. No, he was not hypertensive or diabetic, but he had impaired fasting glucose, for which he was on metformin. And also because of bilateral knee osteoarthritis, he was relatively having a sedentary lifestyle. So no previous complaints about like dyspnea on exertion, etc. was there. This was the first time he noticed. And on physical examination, he was having tachycardia. Heart rate was around 100 per minute, and blood pressure was 140 or 90. And on chest auscultation, he was having bilateral basal crepitations. Rest of the parameters were almost normal. ECG was done, which showed normal sinus rhythm with a little IV intraventricular conduction delay. Then echo was done, and there it was seen that all the 4 cardiac chambers were dilated, and there was global hypokinesia, and ejection fraction was around 30%. So the patient, patient was not much symptomatic. He was feeling better even just by going to the hospital, but because of the crepitations and so much of dilated chambers and low LV ejection fraction, he was diagnosed to have dilated cardiomyopathy, and he was given injectable loop diuretics along with the beta blockers, ACE inhibitors, and then he was sent back home the same day with advice to follow up after 2 weeks. Then after 2 weeks, he went to a further some higher centers for a further evaluation. There, that time he was totally asymptomatic, but he was on the beta blockers, ACE inhibitors, and diuretics. So there again, echo screening was done, and here there were recesses and trabeculations were noted, especially at LV apex, and there was mild non-compaction. Ejection fraction was same as the previous echo. It was around 30%, and there was mild MR and TR. Heart was there morphologically normal, and there were no other existing congenital anomalies. These findings, they led to suspicion of non-compaction of LV myocardium, and for that MRI was done. MRI confirmed the diagnosis and it showed 2 distinct layers, like one thin epicardial layer with compacted fibers, while inner much thicker endocardial layer with non-compaction. And the ratio of this non-compacted layer to the compacted layer was more than 2.3, and there was deep recesses and multiple hypertrabeculations was seen. So diagnosis was made of LV non-compaction, and the patient was continued on the same treatment. Then further he was Holter screening was done. As such, the patient was not having the ECG shows occasional VPCs, but on Holter monitoring there were frequent ventricular ectopics with few couplets. There were bigeminy, trigeminy, as well as a short run of non-sustained VT. Cardiac angiogram was also done, which showed non-critical CAD with about 30 to 40% stenosis in both RCA and LAD mid segments. So because of this arrhythmias in Holter monitoring, he was, can you please, this slide needs to be forwarded. So on the basis of this is an echo, it's not very clear, but next slide, please. Next slide. So here we can see the non-compaction, this in the LV cavity, and with deep recesses also. So next slide, please. The differential of such type of cardiographic picture can be a thrombus also, or some cardiac tumors, or there can be aberrant bands, etc. What is peculiar is that if we do color Doppler, the blood, these recesses are in continuity with the ventricular blood. So that way we can we can think of non-compaction of LV myocardium. After that, next slide, please. This is an MRI. Next slide. MR picture is also showing the hypertrabeculations, especially at the LV apex. Next slide. So Holter and CAG was done. Next slide. And after that, he was thought to be planned. AICD was planned. During the whole course, there was mild ventricular conduction delay was there, but never the QRS interval was more than 110. So CRT was not planned, only AICD was done, and patient was discharged in stable condition on beta blockers, ACE inhibitors, warfarin, and diuretics. Later, the ACE inhibitors were replaced with sacubitril valsartan combination. Next slide, please. Patient is, this is about a year back. Patient is well settled now, and not much dyspnea, not much symptomatic. He keeps on tapering on and off the dose of valsartan sacubitril. And also he has been shifted to dabigatran in place of warfarin. Once, about 6 months back, he had an episode of VT. He had syncopal attack and recovered within 4-5 seconds. And when the recording was seen, there was a episode of VT followed by asystole for 3 seconds. So he recovered, and this is the case of non-compaction. I just wanted to discuss about this case because non-compaction, as in the previous first time he presented, it was not noticed because the level of suspicion is low. Because non-compaction was usually considered as a rare disease, but nowadays the prevalence is around about 4% in those patients with heart failure symptoms, and much higher, around 8 to 9% in those patients having to be diagnosed with cardiomyopathy. So we should be having a level of suspicion in these patients who are presenting with heart failure suddenly without any evidence of coronary artery disease or other comorbidities. So when the level of suspicion is higher, then only we can diagnose these things. Now just think about non-compaction of LV myocardium. Non-compaction has been known since around more than 100 years, but it was initially thought to be associated with other abnormalities, congenital abnormalities, especially the LVOT abnormalities and aortic bicuspid aortic valve Epstein anomaly. It was seen associated with these. But about 80 years back, it was isolated case of non-compaction was also described. And since then, it's being increasingly seen. That is about 4% in heart failure patients. Usually these patients present with the features of either heart failure, or they can present with ventricular tachyarrhythmias, or they can present with thromboembolic events. And the age of the onset, that is the manifestation, they can occur at any age. It's not like that because being a congenital disease, it's going to be present in childhood only. It can present in adulthood also, as seen in this patient. So the main thing is that we should have a high level of suspicion, and main thing for the differential diagnosis, because many times we can confuse this with LV thrombus, we can confuse it with bands, or sometimes in a normal myocardium also can have hypertrabeculations, especially in young athletes is being seen. So the differentiation can be done by the recesses which are in continuation with the ventricular cavity, especially to rule out the thrombus. And how to differentiate that with young adults, that I think the cardiologist, they will be telling more because I'm not a cardiologist at per se, but I think serial echoes, they need to be done, and they keep changing because these trabeculations, like in pregnancy, these trabeculations can increase. So serial observation is necessary. Initially you can miss, but later on, if progressively these are increasing, then you can put a diagnosis of non-compaction. So earlier this was not classified, but presently it is classified as under the genetic cardiomyopathies by the AHA, while the European Society and WHO is considering as unclassified cardiomyopathy. So this was the case. I hope I was able to do justice to my case, because I thought it was a very interesting case, because we don't see such patients routinely. Thank you.
Thank you, Dr. Abha. It was an excellent case presentation, and you have more than done justice to a case. And non-compaction is something that, like you said, you have to keep your index of suspicion high. So basically, if your index of suspicion is high, you pick up more and more cases of this. Like earlier, when we used to talk about hypertrophic cardiomyopathy, we used to see less. And then gradually, when people started picking it up, they realized that there's a lot more hypertrophic cardiomyopathy than we used to think about it. So non-compaction goes the same way. If your index of suspicion is high, if you know what you're looking for, you're going to pick it up. And yes, frequently these patients, they come to us with ventricular tachycardia, and VT is the reason why we lose most of them. And I have had a similar patient whom I implanted an AICD on. But unfortunately, this patient did well for a couple of years, but then he went into intractable VT and he was repeatedly being shocked, admitted in another hospital in an emergency situation. He had lost tie-up with the hospital by that time. So his, insurance allowed him to be admitted in another hospital, and he had intractable VT and kept getting shocked, and ultimately he died. But these are very interesting cases, challenging cases, well picked up, well managed by you. Comments from Dr. Jyotsna, please.
Yeah, it's an excellent case. And I should say that more than a cardiologist, madam, you have a better concept about this case. I can say that. And
Thank you.
welcome, madam. And I think it is primary and secondary, the non-compaction has to be the distinguished, because a few of the conditions where as a secondary cause non-compaction can occur. So that's why the multiple criteria, at least 3 major criteria, Sternberg's and everything is available nowadays on the echocardiography. How do you diagnose a non-compaction? But more interestingly, now, as madam said, it is under the genetic cardiomyopathy is classified. It is going, that is a better one than the saying the primary and the secondary. And even in the primary also, it could be focal to the LV apex, or it may be involved a few of the segments of the LV. All these things can also be known about it. And the major criteria by the Chin and Jenny and Stolberg are the criteria that are required. But it is more important to know whether it is a non-compaction or not, because the long-term prognosis is going to be the vary from the dilated cardiomyopathy versus this. These people are the more likely to have the ventricular arrhythmias when compared to the dilated, even though the dilated cardiomyopathy also can have the ventricular arrhythmia. I'm very great that Vijayalakshmi madam has a 90 cases of non-compaction, I believe. So probably she is a better person to tell to us, but because I have seen only the maybe 10, not more than that.
Thank you, Jyotsna. In fact, when I saw the first non-compaction, I didn't know what it was. I asked Bob Anderson to help me. I sent the pictures. And after he explained to me, I started seeing more and more cases. For Natesh Pandian oration, I presented and published that data also. And I have closed aortoventricular tunnel with the device in a non-compaction in 4-year-old child. So many times we think that heart failure is because of non-compaction, and the associated lesions we forget. So that aortoventricular tunnel was also adding up to the heart failure. So that's how, once that was closed, this non-compaction came down a bit and the LV function improved. So we have to treat the associated lesions if there are. And invariably, along with the non-compaction, in the trabeculate, there will be thrombosis and they will have thromboembolism. So we have to put them on anticoagulants. And arrhythmias are very, very common, and that has to be treated in advance. Okay, thank you very much. And it was a very good case. Excellent.
Thank you, Vijayalakshmi madam. So nice to hear your words of appreciation. Are there any other questions or comments? Incidentally, Jyotsna madam, I'm very happy to have Dr. Abha Pandit here with us. Her father is the chief medical officer of the entire state of Madhya Pradesh, and he has always supported both patients and doctors alike.
Good,
so it is very nice to have her here with us.
Yes, madam.
Thank you, ma'am. Thank you.
We welcome you to the WINCARS also. So please join with us.
Surely, ma'am.
Thank you very much, madam. And even the pediatric cardiologist.
I have one question, actually. In this patient, should we have gone for CRT along with the AICD, or it was right to go for AICD alone? Though the QRS interval was not, QRS duration was always less than 110, but should we have thought, because now after 2 years, when he was seen by some other cardiologists, they were saying that it should have been with CRT. So what is your opinion? What should have been done then?
Yeah, when the patient has an LV dysfunction with the VT, we don't go along with the QRS. It is an indication to implant, even there is a class 1 indication with the CRTD.
Yeah.
But mainly depends upon the how frequently you do it and is going to be then effective or not. That is, and cardiac MRI is another one which is going to be the give you say that in addition to the NECO, the cardiac MRI also gives a good clue. Are you going to have a good responder following the CRTD for this?
Mhm. Thank you,
Yeah.
ma'am.
Yeah, thank you very much. And I'm thankful to all the people of the active participation and real excellent cases. I never seen a few of them, and I don't think in my life I seen both TGA with the TAPPC and the very well managed cases of non-compaction and pulmonary thromboembolism. So unusual presentations and then able to recover completely and enlightening then air pollution leading to the cardiovascular. All the topics are well covered, and I'm very, very happy to you. And individually, I wanted to thank each and everyone, Shiva, who is taking the maximum pains to organize all these things. And
Jyotsna,
not,
I have one point to add with your permission, please, Jyotsna.
please, madam.
Many times, we think pulmonary embolism is DVT. And I have seen 8 children with the pulmonary embolism due to the quadratum dexter, the divided right atrium, which makes the blood stasis, and that causes. It is difficult to make out, but in children without the deep vein thrombosis, from where did it come? So immediately you jump to the conclusion it is the PFO and the pulmonary, the paradoxical embolism. But without PFO, that was the case. So the quadratum dexter, which is called as divided right atrium now by Bob Anderson, is one of the rarest of the rare causes for the repeated pulmonary embolism in children.
Yes, madam. Yeah, I saw the comment on the chat box also.
I know
Thank
it
you
is
very
rare,
much.
but people should keep in the mind, so that they don't miss the cases. That's my idea.
That's true. Yes, madam.
Excellent.
And I thank
Congratulations to you and all the presenters and everyone. Good night.
Thank you all, madam. Thank you, everyone. Each and everyone I want to thank once again. And the supporting people, the Torrent people are so nice. At any moment, they say that yes, even though they have the multiple presentations, they will say that yes, they are paying attention to this meeting and they do it. Thank you all. Good night.
Shiva
Thank
ma'am,
you,
do you
everybody.
want me to add something, ma'am?
I think it's been a great meeting and we've learned so much. So thank you, Jyotsna ma'am, Dr. Sarita, Dr. Sanjukta, Dr. Ava. It's really been great. Thank you so much. And yes, Dr. Kamika for her great inputs on air pollution. Thank you, everyone.
Thank you, everybody. And good night to everybody.
So, as I always say, ma'am, our platform is always available for this WINCARS meeting, which we've been doing regularly. And we look forward for your continuous support with Torrent. And please let us know whenever we can contribute for these meetings, ma'am. Thank you and take care, ma'am.
Thank you.
Thank you, Rahul.
Thank you, Dr. Shiva.
Thank you.
Thank you, Dr. Sarita Rao. Thank you, Dr. Ava Pandit. Thank you, Dr. Sanjukta ma'am. Thank you, Dr. Vijay Lakshmi ma'am. And apologies if I missed out any important name. Thank you, ma'am.
Thank you so much. Thanks.
Thank you. Thank you, everyone. Good night.
Thank you. Good
Thanks
night.
to Torrent. Bye-bye.